Okay, welcome to the deep dive. Today, we're getting stuck into a specific set of revision notes, all focused on migraine.
That's right. Our plan is basically to take these notes apart, find the really essential high-yield stuff, and make it easier for you to get your head around it, whether you're revising or just want to understand it better.
Exactly. We'll work through section by section, from what migraine actually is, right through to complications, all based on this source material.
So think of this as walking through the key facts you absolutely need to know.
Right. Let's dive in. First up, the definition. What do the notes actually say migraine is?
Well, fundamentally, they describe it as a neurological disorder. It's about recurrent headaches, typically moderate to severe ones.
But it's not just the headache pain itself, is it? The notes highlight other key symptoms.
Exactly. That's crucial. Things like nausea, sometimes vomiting, and that really distinct sensitivity to light photophobia and to sound, which is phonophobia.
And some people also experience aura, which often comes before the headache.
Yes, aura is another key feature for a subset of people, and the notes also classify it based on how often it happens. That's really important.
Ah, yeah, episodic versus chronic. What's the difference there, according to the sources?
So episodic migraine means you're having headaches on fewer than 15 days per month.
Okay.
Whereas chronic migraine, and this is a really tough one for patients, is defined as headache on 15 or more days a month. For at least 3 months, and on at least 8 of those days, the headache has clear migraine features.
Wow, 15 or more days. That's a huge difference in impact.
A massive. And the notes list the main types from the International Classification of Headache Disorders, the ICHD. You've got the most common ones, migraine without aura and migraine with aura.
Yep.
Then there are others like hemiplegic migraine, which can be quite alarming, and chronic migraine, as we just mentioned.
The classification even includes complications as a type.
Yes, things like status migrainosus, where an attack just goes on, or even migrainous infarction, which is essentially a stroke related to a migraine attack. Rare, but serious.
And there's couple migraine, too.
Right, if it looks very much like migraine but doesn't quite tick all the boxes. And finally, these episodic syndromes linked to migraine.
Ah, things like cyclical vomiting.
Exactly, or abdominal migraine, benign paroxysmal vertigo, often seen in kids and sometimes without a typical headache. It shows how migraine can affect the nervous system quite broadly.
So definitely more complex than just a headache.
Mm.
Okay, what about the why? The etiology section in the notes, causes and triggers.
Yeah, the sources say it's usually a mix. There's a genetic component, definitely. Environmental factors play a role. And neurovascular influences are key. It's sort of a predisposition meeting a trigger.
And the triggers, these seem really high yield for patients and for a revision, right? What do the notes list?
Oh yeah, knowing triggers is crucial. The common ones listed are emotional stress, that's a big one, alcohol, poor sleep patterns.
Hormones too, right? Menstruation is mentioned.
Definitely. Menstruation, other hormonal changes. Also, physical activity can sometimes trigger one. Certain foods for some people. Sensory stimuli like bright flashing lights or strong smells. And even environmental factors like changes in weather.
That's quite a list. Maybe thinking about them in groups helps. Like internal states, stress, sleep, hormones, things you consume, alcohol, food, and external things, activity, lights, weather.
That's a great way to frame it for remembering them, yeah. Knowing those is really practical.
Okay, which leads nicely into risk factors. Who's more likely to get migraines, according to these notes?
Well, family history is a big one, pointing back to that genetic link.
Uh-huh.
Female gender is also clearly listed. Migraines are, what, 2 to 3 times more common in women?
Yeah, significantly more. And hormonal changes come up again here, too.
Yes, especially around menstruation, pregnancy, and menopause. Also, certain medical conditions are linked, like depression, anxiety, epilepsy.
And lifestyle factors, sort of overlapping with triggers again.
Exactly. Lack of sleep, maybe too much caffeine or alcohol. It's that combination of inherent risk and these activating factors.
Okay, now for the really complex bit, pathophysiology. What's actually going on in the brain during a migraine? The notes seem to suggest it's not simple.
No, it's definitely not just pain. The sources really focus on the activation of the trigeminal-vascular system. Think of the trigeminal nerve, big nerve for face and head sensation, and the blood vessels it connects with.
Right. So what happens when that system gets activated?
Well, it triggers what's called neurogenic inflammation. So inflammation started by nerve signals. This causes the release of vasoactive substances, chemicals that mess with blood vessel tone.
Uh-huh.
And a key result is dilation, widening of blood vessels in the brain.
Ah, okay. So inflammation and wider blood vessels.
Mm-hmm.
That sounds like it could explain the throbbing pain people often describe.
Exactly. The notes also mention abnormal brain activity influencing these vessels and neurotransmitters. There are neurotransmitter imbalances involved, and that whole trigeminal nerve activation cascade contributes to all the symptoms.
It really paints a picture of a dynamic, active process. Makes sense why it feels so different from a regular headache.
Definitely.
All right, let's switch gears to differential diagnosis. Why is this section so important in the notes?
Because, well, a bad headache could be migraine, but it could also be something much more serious. The notes make it clear you have to rule out dangerous conditions first. Patient safety is paramount.
Right. What kind of things need to be on that differential list according to the source material?
Well, other headache types, obviously, like cluster headache, tension-type headache, maybe medication overuse headache, if that's relevant.
Okay, the usual suspect.
But then the really critical ones to exclude: a brain tumor, a subarachnoid hemorrhage that's a bleed, giant cell arteritis, especially in older people.
Temporal arteritis, yeah.
Right. Idiopathic intracranial hypertension, high pressure in the skull, or even a stroke or a TIA, a mini stroke. And sometimes simpler things like sinusitis can mimic it. You have to be thorough.
It really highlights that diagnosing migraine isn't just about ticking boxes. It's also about careful exclusion.
Absolutely.
So how common is this condition? Let's look at epidemiology, the numbers from the notes.
They're pretty striking. In the UK, the sources say around 12 to 15% of people. Globally, something like 1 in 7. That's a huge number.
Wow. And the gender split.
Yeah, we mentioned it with risk factors. The notes confirm it's 2 to 3 times more frequent in women. About a third of women might experience it in their lifetime compared to maybe 13% of men.
And the typical age.
Peak seems to be in the 30s and 40s in the UK data, maybe 25-55 globally, according to the notes. But they stress it can affect anyone, any age, even kids.
And here's a point the notes really emphasize. It's often underdiagnosed.
Yes, in both primary and secondary care, which is kind of surprising given how common it is.
It makes you wonder why, doesn't it? Maybe people just put up with it, think it's just a headache, or the presentation varies so much.
Could be a mix of all those things. Definitely something to be aware of.
Okay, so what does an attack actually feel like? Let's delve into the clinical presentation based on the notes.
Right. The sources describe the typical headache again. Moderate to severe pain, often pulsating or throbbing, frequently unilateral one-sided, and characteristically worsened by normal physical activity.
And those associated symptoms are usually there too.
Yep. Nausea, vomiting, that sensitivity to light, photophobia, and sound, phonophobia. And sometimes the aura precedes it all.
The notes break down the stages of an attack, which seems really useful for understanding it.
It is. First, there's the prodrome. This can start hours, even a day or two before the actual headache. It's often quite subtle things like yawning a lot, mood shifts, maybe neck stiffness, changes in appetite.
Sort of like warning signs if you recognize them.
Exactly. Then, for those who get aura, comes the aura stage. The notes describe this as fully reversible neurological symptoms, usually building up over minutes and lasting less than an hour typically.
And mostly visual.
Visual is most common, yeah. The notes mention transient hemianopia, losing half your vision field, or that classic scintillating scotoma, like a flickering, jagged arc of light that spreads. But it can be sensory too, like tingling or numbness spreading, or even affecting speech. It usually happens right before the headache or overlaps with the start.
Okay, then the main event. The headache stage.
Right, lasting anywhere from 4 hours up to 72 hours if it's not treated effectively. And it has those features we mentioned, usually unilateral, throbbing, moderate to severe, with the nausea, vomiting, and the tone the light sound sensitivity.
And after the headache finally goes.
Then comes the postdrome, often called the migraine hangover. It can last a day or two. People feel drained, fatigued, maybe still have mood changes or difficulty concentrating.
That whole sequence sounds incredibly disruptive.
It really is. And that's why the notes stress how serous the headache history is for diagnosis. You need to ask about everything: how long attacks last, what the pain feels like, where it is, associated symptoms, triggers, what helps, what they feel like between attacks.
That detailed story is key to matching it to the diagnostic criteria.
Precisely. The notes also mention kids might present differently, maybe more bilateral pain, more in the middle of the head, and GI symptoms can be more prominent.
And menstrual migraine gets a specific mention too.
Yes, linked to that drop in estrogen just before or during menstruation.
What about examining someone? What do the notes say you might find?
Interestingly, between attacks, the examination is typically completely normal.
Okay.
During an attack, you might find some localized scalp tenderness or maybe slight swelling, but often not much. The key examinations listed in the notes are really about ruling out other things.
Right, checking fundamentals.
Yeah, always check optic fundally, look at the back of the eye, check blood pressure, examine the head and neck. And in children, measure head circumference. These are checks for potential red flags.
Which leads us perfectly into investigations. The notes seem clear diagnosis is mainly clinical.
Overwhelmingly clinical, yes, based on that history and a normal exam usually.
So investigations are reserved for specific situations.
Exactly, primarily when there are red flags present. These are warning signs suggesting something else might be going on. Remembering these red flags is super important for revision and safety.
Okay, what are the key red flags listed in the notes?
Things like a new headache starting in someone over 50, a significant change in the pattern of their usual headaches, or if they have systemic symptoms alongside the headache, fever, weight loss, that kind of thing.
If you see those, you investigate further.
Definitely. And the notes specify which tests for which scenarios, like an ESR blood test if you suspect temporal arteritis,
Right.
a lumbar puncture, a spinal tap if the headache came on like a thunderclap, or if there are signs of infection like meningitis, or suspicion of a bleed like subarachnoid hemorrhage.
And imaging, CT or MRI?
CT brain is usually for emergencies, like suspected intracranial hemorrhage. Imaging specifically looking for brain tumors is indicated if you find things like papilledema on fundoscopy, new seizures, or focal neurological signs on examination.
The notes also mention yellow flags.
Yeah, sort of less immediately worrying signs, maybe suggesting migraine variants or things like memory disturbance, distinct from the serious pathology red flags like the new onset over 50, atypical aura, or that worst ever headache.
And if someone has clear neurological symptoms during an attack,
Mhm.
like weakness,
That might point towards those migraine variants like hemiplegic migraine, and the note suggests those might also need investigation to rule out other causes for those focal symptoms. It's all about being vigilant.
Okay, so let's put it together. Diagnostic criteria. The notes give specific criteria for migraine without aura. This seems like core revision material.
Absolutely. The sources lay out criteria A through E. A is pretty simple. You need to have had at least 5 attacks that fit the description.
It's 5 attacks. Okay. B.
B is duration. The headaches have to last between 4 and 72 hours, assuming they're untreated or treatment didn't work.
4 to 72 hours. Got it.
Yeah.
Criterion C is about the headache features.
Right. You need at least 2 out of 4 specific characteristics. The notes list these as pulsating quality, unilateral location, moderate or severe intensity, and aggravation by routine physical activity.
That's where that PUMA mnemonic comes in handy, right?
Mhm.
Pulsating, unilateral, moderate, severe, aggravated by activity.
Exactly. PUMA. A really good way to lock those 4 down from the source material.
Okay, PUMA, then criterion D associates symptoms.
Yes. During the headache, you need at least one of the following 2. Either nausea and/or vomiting, or both photophobia, light sensitivity, and phonophobia, sound sensitivity.
So feeling sick or bothered by both light and sound.
Correct. And finally, criterion E is just that the symptoms aren't better explained by another diagnosis, which takes us back to the importance of considering differentials and ruling out red flags.
Makes sense. The notes also briefly mention typical aura again.
Yeah, reinforcing that progressive nature, the visual disturbances like the spreading scintillating scotoma or sensory speech symptoms developing over minutes.
And they compare to NICE criteria slightly.
Just noting, NICE might be slightly different on location, unilateral or bilateral, or timing details. But the core message is the same. Diagnosis is clinical, rule out other stuff, investigate if needed, so MRI for structural issues if atypical.
Right, so we have a diagnosis. How do we help? Management, the notes split this into acute and prophylaxis.
Yep. Acute treatment is for managing an attack when it hits. First line, according to the notes, a combination, an oral triptan plus an NSAID like ibuprofen, or an oral triptan plus paracetamol. Taking them together seems key.
Okay. And for younger people?
The notes mention nasal triptan as a good option for adolescents, 12 to 17 years old.
What if that combination doesn't cut it?
Then the sources suggest trying non-oral options, particularly antiemetics like metoclopramide or prochlorperazine. These can help with the headache itself, not just the nausea, and getting around the vomiting issue if that's happening. Antiemetics are generally important if nausea vomiting is significant.
Okay, that's for stopping an attack. What about preventing them? Prophylaxis.
Right. prophylaxis is considered, according to the notes, if someone's having frequent attacks, say 2 or more per month, that are disruptive.
And the main options listed.
The primary medications mentioned are topiramate or propranolol. The choice depends heavily on the patient, their preferences, other health conditions, potential side effects. It needs individualizing.
Are there non-drug options mentioned for prophylaxis?
Yes, the sources list acupuncture and high-dose riboflavin, vitamin B2, as things that may help some individuals. Evidence might vary, but they're listed as options.
And there was something about menstrual migraine.
Ah, yes, mini prophylaxis. For women with very predictable menstrual migraines, the notes suggest using a triptan, specifically frovatriptan or zolmitriptan, just for a few days around their period.
And something that's not recommended anymore.
Pizotifin. The notes explicitly state it's no longer recommended for prophylaxis, likely due to side effects or better alternatives. That's an important point to note.
Definitely. What about non-prescribing management generally? Lifestyle stuff.
Hugely important, especially for chronic migraine. The notes stress lifestyle adjustments. Identifying and avoiding triggers where possible, back to that list again.
Right.
Maintaining good sleep hygiene. Developing coping strategies. And behavioral interventions are also mentioned, things like mindfulness or CBT, cognitive behavioral therapy.
There are also some really crucial considerations, particularly for women, mentioned in the notes. Contraception and pregnancy.
Yes, absolutely vital. The link between migraine with aura and increased stroke risk is highlighted. Because of this, the sources state that combined hormonal contraceptives, the combined pill, are contraindicated. They should not be used by women with migraine with aura or often migraine without aura if other stroke risk factors are present.
That's a major safety point. What are the suggested alternatives then?
The notes list progestogen-only pills, the mini pill, or hormonal implants as acceptable options.
Okay. And during pregnancy or breastfeeding, what do the notes advise?
Migraine often improves during pregnancy, especially later on, but can return afterwards. For acute attacks during pregnancy, paracetamol is preferred according to the notes. NSAIs like ibuprofen might be okay earlier on, but should be avoided after 30 weeks.
In triptans.
Triptans should be avoided during pregnancy, the notes say, because there's limited safety data.
What about prophylaxis if it's really needed during pregnancy or breastfeeding?
The notes suggest propranolol or amitriptyline could be considered, presumably after careful discussion of risks and benefits.
Okay. So looking long-term, what's the prognosis according to the source material?
It's described as a chronic condition, which sounds a bit bleak, but the key message from the notes is that it often improves with age.
That's somewhat reassuring.
Yeah, an improvement after menopause in women is specifically mentioned, as is that potential improvement during the second and third trimesters of pregnancy we just talked about. So the severity isn't necessarily constant throughout life.
Good to know. Lastly, complications. What potential issues beyond the attacks themselves do the notes mention?
Well, the obvious one is the massive disruption to daily life work, social life, relationships. That's huge. There's also a well-established link mentioned with psychiatric conditions. People with migraine have an increased risk of depression, bipolar disorder, anxiety, and panic disorder, according to the notes.
And any direct neurological complications?
Yes, though rare. Status migrainosus, that attack lasting over 72 hours, and migrainous infarction, basically, a stroke that happens during a migraine aura. Very serious.
Wow.
And beyond that specific event, the notes also mention a general increased risk of both ischemic strokes from clots and hemorrhagic strokes from bleeds in people with migraine, particularly those who experience aura.
Which really hammers home the importance of good management.
Absolutely. The notes conclude that section by saying proper management, identifying triggers, using acute and prophylactic treatments appropriately. All this can help reduce the frequency and severity of attacks, minimize complications, and improve outcomes.
So wrapping up this deep dive into the migraine notes, we've covered a lot. From the basic definition and the complex neurovascular stuff happening underneath.
Through how it presents, the stages, the crucial differentials, who gets it, how common it is.
Right through to the diagnostic criteria, remember PUMA. The management strategies, acute and preventative, and those important considerations around contraception and pregnancy, plus potential complications.
It's clear from these sources it's a major neurological condition, far more than just a headache, impacting a huge number of people. And yet, as the notes highlighted, it seems to be frequently underrecognized.
Which leaves us with a thought for you to consider, especially if you're working in healthcare or revising this topic. Given everything we've discussed, its prevalence, its impact, the potential risks, And this issue of underdiagnosis, why? Is truly understanding migraine in all its complexity so vital? What happens when we don't get the diagnosis or management right for patients? Something to reflect on.
We hope this walkthrough of the revision notes has been useful and made the key information more accessible.
Thanks for joining us for this deep dive. If you're looking for more resources based on this kind of material, particularly for MSRA revision, do check out pastthemsra.com.
And you can also find resources at freemsra.com. Thanks again for listening.